Greetings and welcome to the Building Bridges Initiative webinar that's entitled Successfully Engaging and Partnering with Families. My name is Sherri Hammack and I'm the coordinator for the National Building Bridges Initiative. And I'm joined with Patrice, Flagle, and Joanne Hunt. And Patrice is from Catholic Charities in Maryland, and Joanne Hunt is in Arizona and joins us there as a consultant representing the family perspective. And I'm going to let them introduce themselves at more depth when they take their turn to speak. So with that, I want to give a quick introduction to the Building Bridges Initiative and provide that framework, and then work us into the Partnering with Families presentation. So BBI, as we fondly refer to Building Bridges Initiative, our mission is really to advance those policies and practices that are grounded in research on sustained positive outcomes post-discharge from residential interventions. And we do that through promoting partnerships and strong collaborations between family and youth and community-based providers, as well as the residential intervention providers and policymakers and system decision makers as well. So putting that all together in that frame, it's really grounded in values that are family-driven, youth-guided, strength-based, culturally and linguistically competent, and again, like I said, with the grounded in evidence and the research and what the data shows. We have very many partners, and here on this slide is listed a few, and they work in tandem with us, and we work with them as well in advancing those best practices and policies that help support those positive outcomes post-discharge. I just wanted to name a few there. If you're interested in knowing kind of the backdrop to BBI, I would point you to a legacy document that we fondly refer to as the Joint Resolution, and that really gives a good history of how BBI came about. And that's located on the Building Bridges for Youth website. If you read that and you think, well, this is something that my agency or my organization can really buy off on and get behind, I invite you to email myself or Beth Caldwell, who's the director of BBI, or Dr. Gary Blau, who works at SAMHSA at the federal level, and say, we'd like to endorse this. We need to get an email from you, from your CEO. And then you would be put on a list of partners to BBI, but also be on a distribution list to be the first to be invited to BBI events or newly developed documents. This is an example of one of the documents that has come out recently that really highlights many different programs talking about how we should look at short-term lengths of stay in residential interventions and how that really yields the best outcome. So there's a lot of good information in that document, and I would invite you to go on the website and you can download that. This is the top one listed on this particular slide, and you can see some of the other documents, the guidance documents or informational documents that have been developed. If you're interested in continuing education units or CEUs, the website at the top with the University of Maryland, there's a lot of training webinars here that can give you some background in BBI, and you can obtain CEUs as well. So I invite you to do that. You could have a book club or a webinar club and listen to a webinar and then get a few of your colleagues to sit down and discuss. So one of the trends that we're seeing coming down the pike right now is the Family First legislation, and that's really an important piece of legislation that's been passed February 9th, 2018. And this particular law is expanding the use of 4E child welfare entitlement dollars to prevent foster care. And I'm learning more and more about it. I'm certainly not an expert, but I know that the BBI framework and the values and missions of BBI is certainly in line with this particular piece of legislation. And I would also give you some resources here if you'd like to learn more about that. I know that many states and jurisdictions are looking forward to more federal guidance around this law. So here the first link is the law itself and some summaries of the, or cliff notes, if you will, from the law that you're invited to look at to find out more. So the next slide really lays out the core principles of BDI, and I mentioned that those line up very nicely with the Family First legislation, but also just, you know, with respect to young people who are receiving residential intervention. So one of the core values in BDI framework is the family-driven care piece, and that's what we'd like to talk with you about today. And I really like this picture and this particular guide, Family-Driven Care, Are We There Yet? And that University of South Florida did back in May of 2007, because it really puts families in the driver's seat, and I think that's what we're shooting for when we're looking at what is family-driven care and how we do our work. So when we ask what truly is the definition of family-driven care, and I know many of you out there have done this work and are familiar with it, but what we mean when we talk about it in terms of the BDI framework is really from a twofold standpoint. And the first one meaning family-driven means that families have the primary decision-making of their own plan of care for their children. So it's not like there's meetings going on about a service plan or a treatment plan or a plan of care without family there. And the common motto is nothing about us without us. But it goes back to that picture of families being in the driver's seat and being a part of driving that plan of care and saying, this is what will work with our family, and this is what may not work. The second part of family-driven care is that families are at the table when organizations and programs or systems are developing policies and procedures that are developing or implementing or evaluating, for that matter, rules and practices that are being conducted within that organization. So that's the second part of family-driven care from an organizational level. What's really important to know is that 50% of the youth that have aged out are going to go back and live with some member of their family, whether that's parents or other relatives, within a couple of years. That's what the research has told us, and that the strongest predictor of post-transition success after receiving education is support from the family. So we know that working with families, and again, we know this based on research, that if we're working with families in their home and in their community while they're in residential interventions or treatments, that will have gains as much as a year after discharge. The other research really tells us that shorter lengths of stay and making sure that when we are looking at residential interventions that they're purposeful and we're measuring outcomes for what we're trying to see with that intervention, and that we have an increase of family involvement, and we're really looking at that post-residential environment and making sure that there's support after discharge. So what can programs do? Now what? Here's three things that I would point you to, and you're going to hear more about this from Patrice and Joanne. But I would suggest that number one, first and foremost, is to put an urgent and strong focus on permanency practices. What is the permanent home for that young person that you're serving? And making sure that you're looking at that transition and that discharge beyond at admission. And secondly, that you're hiring multiple family partners and advocates, not just one family partner, but multiple family partners that they're hired and supported to help inform other families, to help inform staff, and work with young people. And thirdly, I would suggest that a strategic plan to purposely sit down and look at ways that you can operationalize family-driven care and successfully engage families within your organization would be a great way to start at looking at implementing family-driven care. So here's a last little tidbit from the BDI website, and I see these are mostly in Spanish, and they're in English as well, but there's family tip sheets and youth tip sheets and tools for you there that's a good starting place as well to look at how to start off with family-driven care. So with that, I'm going to turn the program over to Patrice Flagle and let her talk to you about some potential strategies that you could consider.
Thank you, Sherri. I'm Patrice Flagle, and it's a pleasure to be here with all of you today. I've been blessed to work for Catholic Charities for the past 11 years. I'm a social worker by profession, but I was hired to do program development as well as consulting and therapy. Somewhere along the line, they threw in administration as well, and I'm just truly happy to be working with such a creative and innovative program. It's far from perfect, but we really have the focus on supporting families and children. I'm going to start with talking about families. Families, I think we have to come from, we can talk about them all we want, but for my staff and for myself and whenever I think about families, I like to take a minute to think about our own family, because then we come from it from a really internal, a really real perspective. You know, we all come from families. We're all part of families. Families are the core of everything. They factor into who we are. We have different levels, all of us have different levels of family imperfections and imbalances, and we're really looking at treatment as a team effort with equal partnerships with families, youth, and professionals. And that's so important. It's just not a family member coming in and saying, is this treatment plan okay with you? It's really having a family member come in and say, what do you want us to do? How do you want to work with us with your child? And that's a completely different perspective. So that's really important. There's been a lot of research, as Sherri was saying, over the past 10, 15, even 20 years on the importance of involving families in treatment with kids, and especially in residential care. Years ago, when children came into a residence, they were here for years and years and years. The state and really dedicated care workers provided loving, nurturing care for them, and the families were sort of excluded and labeled as maybe not good enough, or they had problems, etc. We know that that was one of the worst things we could ever have done, because we really believe now and know that it's evidence-based that involving a parent or any concerned adult in the child's care and treatment, as well as then planning for adequate supports for discharge, are the two consistent indicators of successful treatment. And that's just, you know, we can cite study after study that show that these two factors, aftercare planning while they're in treatment, as well as the steady, consistent involvement of that significant other, are paramount to success. And so they really underscore the need for consistent family contact and involvement with each child during and even after their placement. And, you know, I'm probably speaking to the choir, because most of you, if not all of you on this call, are probably already doing a lot of this work, or you wouldn't even be interested in what BBI has to say. So it's nice to be with you all. But before I get into the specific tools for implementation, I'm going to talk a little bit about our program very briefly, just because it'll give you an overview of how we've used a lot of these tools for implementation, and we're still adapting and changing. Like I said, we're far from perfect, but what we're willing to do is continue to self-reflect and adapt as we go along. So what we have, we've added some new ideas to the age-old existing RTC philosophy of providing safe and nurturing environments with quality, compassionate treatment and care. And again, my sense is all of you are already doing so much of this with your, whether it's foster care, adoptions, transitional services. I've been on calls with Rhode Island over the past week, and I'm amazed at some of the outstanding work that's already been done. So we're not saying stop doing that. What we're doing is saying let's add some spokes to the wheels. You know, let's keep what's working really well and just add something to it. Add a little extra spice. The spice of really making that the family a paramount, not just the side piece, but the core of the treatment. Our program is an intensive short-term residential program where we serve children between the ages of 6 and 14. And they have to be less than an hour and a half away from our facility. And we're in Central Maryland, so that we can serve most of the state in that way. And it's really based upon families and staff working together. So our unit literally closes on the weekend because the children are here in the residence. Even though we're an RTC, a residential treatment center, they live here Sunday evening through Friday after school. And every Friday afternoon, no matter what happened during the week, no matter what the behaviors were, staff or the therapist will transport the children to their homes wherever they are, set some goals with the parents and the children together, and then provide ongoing support throughout the weekend to the parent and child in the home. Because we really wanted to be that the factor is that the children continue to live at home while they're living treatment, because that is their home. And they come to us during the week. It's kind of like a therapeutic camp, but it's a completely different perspective. We're still a residential treatment center, but it really changes how we look at the separation of children and families, and it helps the children with their own sense of separation, or lack thereof at this point. So this is really, when we were told that we had to make it a short-term program versus years and years, we were wondering, how are we going to do this? We can't just work quicker, because we know quicker can get sloppy. So we realized that had to be a complete paradigm shift. And so it's a constantly changing wheel. We knew we wanted to maintain immensely committed to high-quality short-term work, and it's part of our continuum of services. And so for this to be effective, there has to be a constant reevaluation of the program with staff, families, children, what's working and what's not working. You have to be really able to be humble, be transparent, remembering that we may be the professional experts. We know about mental health, we may know about behavior modification, but each parent or each grandparent or each uncle, whoever is that significant other in that family, they know most about that child and family, and they're the expert on that family. I remember when my first child was born, and as we are as new parents, and we call the pediatrician every time they look different or breathe different. And finally, Dr. Muncie said to me, Patrice, I'm the medical doctor, and I've got medical expertise, but you are going to be the expert on David. You are going to know him inside and out better than anybody else. And you're going to be able to tell me if he looks off, if this is different for him, etc. And if we choose not to ask these questions of parents when their children come into care, we are missing vital diagnostic criteria as well as ongoing assessment. And so these parents are the experts in their child. And so I think it's really important to remember that and to empower them, that they're not giving us their children, we're all working together. And so common goals. So as I said earlier, and as Sherri said, there's been so many studies, and we're really looking for more positive long-term outcomes. And the part in 2005, as well as others have noted, that family-focused residential care obtains much more positive long-term child outcomes. So family-focused, family-driven, you hear the same thing again and again because it works. It really does. And therefore, efforts must be made to honor and strengthen the attachment between families, not re-traumatize families. So many times when children come into care, just separating from their families is a traumatization of itself. And so we don't want to do that. What we want to do is strengthen those relationships. So the most significant task for our counselors, for our therapists, for our administrators, for all staff is to not only build a therapeutic relationship with the child, but also with the family members. And I have to tell you that this is really effective when working with the children. If they see that their mother or grandmother is starting to trust you a little bit, I guarantee you that they're going to open up a little bit. It's kind of like one hand, they kind of go hand in hand, a domino effect. And if the parent sees that your child is starting to open up with you, then they're going to trust a little bit. And it's like step by step, we build that trusting relationship together. And so we have to have a new focus. So we're no longer fixing the child. We're finding ways to balance and realign the family system. And we're looking at ways to preserve family connectiveness. We're strengthening family relationships. And we're building upon existing strengths, adding spokes to the wheels. In doing so, we want to maintain safety. I know in the child welfare system, in our program, we're lucky, or it's just the way it works, that we only accept children into our program if they have a significant other to go home to, whether it's the neighbor who's been guardianship, a best friend, a grandmother, an uncle, a foster parent, or whatever. And I know that lots and lots of kids don't have safe homes to go home to in that moment. So even if you can't send the child home because of whatever regulations are in place for safety, et cetera, you can still maintain positive contact with that family member. Because as Sherri said earlier, and if you look at all the research, no matter what happens, even if kids stay in care until they're 18 or 21, depending upon what state you are in, I guarantee you these children are going to reconnect with their families when they're discharged from care. It's a given. And so, you know, if you're concerned about the safety of that system, while the child is in care, just think about what happens when the child leaves. So I think it's much more effective, even if you're sending a child to foster care or transitional care, to still work with that biological family if they're available and make ways for them to be available, so that you're kind of balancing that system a little bit. So, you know, things are still going to be imperfect, but maybe they're a little bit more safe by the child by the time the child does go home. What you want to do is just build for success and make the best lemonade out of whatever you have, and just really honor those family relationships. Because I guarantee you, as we all know, most of these kids are going to connect with it. That's what we do. And so we really want to help families make these changes. Now, for the families where they are the discharge resource for the kids, it's really, really important for us to really help them make changes in their home while the children are in care. It's not like the old days where we wave the magic wand over, you give us your child for a year or two, we do some magic pixie dust, and we send you home a new and improved kid, and everything is fine. It's not that way. That never worked anyway. But really what we need is where everybody's working together. And I interview every family before a child's admitted to our program. I either go to their home or they come in here and we talk. I tell them about our program. I tell them about me. I ask them about them. And everybody says, yes, I want to change. Everything is great. And as soon as we ask people to make changes, because we're all the same way, it's like, oh no, really? Do I have to try that? And I ask them, just please try. You may think I'm crazy, but just try little things. Because what we do know is if the system doesn't change, the treatment with the child is not going to work. So we're really looking at not fixing, but balancing. If we all look at our own lives, if our own relationships, who cannot stand to have a little bit balancing? We can all be balanced a little bit. So I think when we do that, when people get that, it's really much more effective. So tools for implementation. First area, and I'll have slides for each of these in a moment, but I just want to list what they are. The first one is vision and goals. You have to have a clear vision of where you're going. You have to focus on the generational trauma. It's just not the child trauma. This cycle of poverty and trauma has been going on for generations. And so we have to look at the big picture. Family goals, not just what we want as the professionals. Ways to build therapeutic relationships with all the family members. Building a structure for your program, because when we talk about enriching relationships with families, you're shifting the structure of your program a little bit. Sometimes a lot. It depends upon the type of program that you have. We're going to be talking about working in the homes. It's my preference. I think so much more happens. There's very little you find out in 50 minutes in the therapist's office or in an intake meeting. That I guarantee that you find out so much more when you walk into a living room and see the family pictures all over the walls. Supervision, training, staffing, team building, these are all imperative because we're asking people to work differently. We suggest often parent educational support groups. And the important thing for this, when we're talking about short-term care and working with various people, you have to communicate with everybody in real time or things get missed. They get miscommunicated. And when things like that happen, you're decreasing that family engagement, and we're looking at ways to increase the family engagement. So we're going to move ahead to vision and goals now. So it's really family-driven care, and you have to take a minute. What does that mean to you? You know, it's a philosophical, it's a paradigm shift. And for this to really happen in your agency, it has to start with leadership, really believing in this. Doing some self-reflection. We do a lot of leadership retreats. We do a lot of management meetings where we're honest about, are we where we want to be? And where do we want to be? And what are my thoughts? Because sometimes, you know, I'm one of the more progressive people here, and sometimes I get one of those little nigglings. Can we really do that? Is that really going to work? That doesn't quite make sense to me yet. But we have to be able to be honest about it. Because if leadership can't work through those kinks, then we can't, in an authentic, genuine way, pass down information and then include staff and parents and children in the planning process. You have to have your core be strong and then open so that when we present information to people, it's not this is what the program we're going to do. We're presenting our vision, and then we're open and flexible to add everyone else's opinion and feedback to that, so that then you have kind of a moving target. So you really have to focus on the facilitation of the entire family system in the healing process. We're done with labeling people as bad or non-compliant or resistant. I hate those words. And looking at ways to be creative and courageous. So take a minute right now and think about your own program. Think about where you are in your program with the family, with the level of family engagement. And where do you fit into that process? And take a minute. What's working well? And give yourself a little pat on the back for that. That's good. I know all of you have things that are working well. And then be honest and just note down at least one thing you might be willing to look at changing just a little bit. And then you can come back to that later. So family engagement is the most significant variable in the process. And we really have to change our perspective and attitudes regarding families. We need to build on the therapeutic relationship with the whole system. Got to focus on safety. And the family consists of anyone. We do what we call family nights every Tuesday night. And somebody said, well, can I bring the youngsters? Well, of course you bring the youngsters. Most people don't have money for child care for their siblings or whatever. Can I bring grandma? She lives in the house. My next door neighbor, he helps every day after school with child care. Absolutely. Anybody who is a significant support to this child and to the parent or to the grandparent or the great-grandparent, because we have great-grandparents in our program, needs to be considered part of this process. We've had many instances where we work with therapeutic foster parents as well as the bio parents simultaneously together in the same room where they're all having pizza together with the child and supporting the child, and then the therapist does a session with them all together. You have to be inclusive and be aware of your family's existing strengths before we attempt change. You know, often as therapists, we come in, or administrators, and you're looking at what families should do, where they need to do this. I know child welfare agencies, and if you're out there, you're doing a great job. It's a hard job. But often there's a parent contract, and you have to do 10 anger management classes, you have to do 10 parenting classes, and you have to do this, and you have to do that. The parent leaves feeling, number one, lower than low, and totally lacking in trust for anybody who's considered a professional with any kind of mental health agency. And so part of our job is kind of chipping away at that wall that many people have put up because they have felt put down, discriminated against, or criticized, and really look deeply and ask in a genuine way. And it's not hard to see sometimes when you put on a different color glasses, what is really working. Because my basic belief is all parents love their kids. They may not be able to express it in a safe and effective manner, and we may need to teach them that. And some people may not be able to be taught that enough where they can actually raise their kids. But for the most part, all parents love their children. And then look for ways that they're expressing their love. You know, maybe it's because they're worried about the laundry not being done properly, or things that we don't think are clinically indicated. Who cares? We're worried about aggression and self-harm, and they're worried because we lost their socks and they didn't look nice going to school. You know, so I think it's really, really important to change the prescription of our glasses as professionals and really look at what is already working in that family in these kind of day-to-day mundane details, because the love is in the details. And I think sometimes we overlook them looking at the big picture. I have an interesting definition of family. I was trying to find a definition of family, and I skimmed lots of them. So one from the New York Times that is exactly what we're talking about. The definition of family to me is a group of people who truly love each other and care for you. And yes, the circumstances of what family used to be is now changing into new categories of families. Family life is changing, but so are people. I love that. So the concept of family is continually evolving. Any adult who has an ongoing relationship and provides support to that youth, you know, it's family. How many people, when they go to church, my kids growing up had so many aunts and uncles that had no blood relation to them. But I guarantee you, these people have been there for them in their lives as I've been there for other people's children. So it doesn't have to be necessarily only your blood relative. So in building therapeutic relationships, I think the most important thing you can do is to be authentic, to be real. In a respectful manner, you got to be able to call it like you see it. You got to be down to earth with people. You got to be able to laugh a little bit. You got to be able to make little jokes. You got to be able to notice, again, the details. You got to have to find ways to mix the formal assessment, formal therapeutic process with the informal, getting to know you while you're still maintaining personal boundaries. It's kind of a mixed bag. It's tricky, and that's why when we talk later about staffing patterns, when we're increasing family engagement, it involves a lot of supervision, ongoing supervision, and peer supervision as well. For example, I might tell everybody that I have 4 adult children. Do I tell them the details of my children? No. But I let them know that I'm a parent and I survived that. And coming to work every day, most days is easier than it was when I was raising the 4 kids. You can say that. That's kind of a general statement that just you connect with them. That they know that you know how hard it is when you got a sick kid at home and you're trying to get to work or you're trying to figure out things. But we don't want to then disclose all the details. So it's a fine line, especially when we're working in homes with people. And that's why this is a discussion that can go on and on. We'll get into a little bit in a minute, but it's just important. So I just want to focus on, even though we're talking about building these relationships, we still have these professional boundaries. We want to involve as many family members as possible. I have a photo that I don't have here today, but we did a discharge planning meeting, my aftercare coordinator and I, about a year ago in Baltimore City, right in the middle of where they had those riots a couple of years ago in Section 8 housing. And it was one of our most highest profile kids we've had in residence in years. And when we got there on a Sunday afternoon, because that's when the grandmother could get most of the people involved, we went on a Sunday afternoon. There was standing room only, and some people were sitting on the floor. They had folding chairs that the neighbor had brought down. There were 22 people in this little tiny Section 8 living room that wanted to help do aftercare planning for this child. And they all felt that they were family to him, that they all loved him, and they wanted him to be successful. They were proud of him for all the progress he had made. And this child, it's now been a year. He was discharged last August. It's now been a year, and he's still successful. And the grandmother is amazing, but she works full time, but it's not without the support of his older brother who doesn't live there, and another uncle, and an aunt, and several different neighbors, etc. So again, it takes a village. We want to be strength-based, so really notice the details. I can't emphasize that enough. I notice so many details when I walk into a home. Number one, you always see photographs. And you find out, and notice, focus on the love. You know, I think so often we say, oh, we don't want them to hit him anymore. We don't want this to happen. We don't want that to happen. But take a minute as professionals to use the love word and focus on the love. Because when we talk about families, we're talking about love. People love their kids. And as mentioned, the color of your glasses. We have to just try to be more accepting and compassionate versus judgmental. Doesn't mean we ever ignore safety issues, because we do not. Because acceptance never equals approval. Got to keep it real. We take time to build trust. People are not going to open to us overnight. I'm not going to open up to people overnight. If you go into a doctor's office, you're not going to tell him everything. You're going to tell him what you think he needs to know in that given moment. Keep checking in. What does the family need versus a standard treatment goal? You know, and what might have happened the day of admission may be different a month down the road. So treatment goals should not be in stone. They're good for that 30 days. And then check in with the family. What do you really need now? Tell us what you really need. What do we really want to work on? I love this saying. My father always said this to me: never judge another Indian until you've walked a mile in their moccasins. And I love that. You know, just really try to think about what it's like for this family. You know, we look at cultural issues. How can you not look at cultural issues? We need to celebrate diversity. And while we're celebrating, we also need to acknowledge that we're not where we are as a country, as a world, because we need to acknowledge at times that the cultural, sexual, racial, and socioeconomic issues exist. And even if we don't see any differences in people, because that's not how we're wired, the world does, and sometimes we're perceived differently because of these issues. And if you can't talk about it, you can't get through it. Because no matter who we are, we're some of all these experiences. And a lot of the folks that we work with have had really bad experiences with, again, professionals or et cetera, or people of a different color or et cetera. And so you just have to know, you have to be able to talk about those differences with people. You have to be able to accept where they're coming from and let them know who you really are, but take time to build that trust. But you can't pretend they don't exist. Because if you try to pretend they don't exist, you just kind of, the system just goes on and on and on. This stuff really does exist. And when you talk about it, then you can kind of knock down those walls slowly so people realize that we really are all in this together. And it's really important for staff. I mean, in our program, we have multicultural staff, multicultural kids. We have kids urban, for a lot of African-American population from downtown urban Baltimore. And we have a more of a lower income, very low income Caucasian population up in kind of the rural areas of different counties in the state of Maryland, kind of really out there, where there's actually less services available than in the city. And so when we send staff of various, different places, we have to be able to talk about these issues, making sure people are comfortable and safe going into different neighborhoods. And my sense is most of our staff they are safe, or that we wouldn't be sending them, number one. But number two, they have to feel that in their heart. And if they're not, we work with them until they are, but we never send anybody any place until they have that level of confidence inside that they're feeling safe about that. And you have to be able to process it. You have to be able to talk about it. And it's really, really important, not to just pretend that it doesn't exist. We're talking about providing family-driven care and enhancing family engagement. And we're working with, quote unquote, these poor little traumatized kids. We have to realize that most of our kids come from families where the trauma didn't start with this current generation. A lot of the trauma has been going on for years and years and generations. And what we really want to do is really time to break that cycle. It's time to stop blaming the family and seeing what we can do to balance and support, offer resources where needed, teach people to fish, not enable them, but help them to fish. So we have ongoing assessments, informal and formal, because you find out more and more about people as you get to know them. And again, acknowledging the efforts, acknowledging the small efforts at times, that things are effective. Because from social service agencies, et cetera, they're used to getting the criticisms of you didn't miss this meeting or you didn't do that. The positive feedback goes a long way. And focusing on the system as a whole. Do they need housing? Do they need food? Do they need transportation assistance? Legal aid? We can talk about mental health all you want, but of course you're going to be depressed. And if any of these other basic needs are not being met, that's Maslow's hierarchy of needs. You've got to help people find the resources to meet basic needs as you're working along with the mental health issues. Looking at family generational trauma, we see that all events in families affect each family member, but not always the same. 71% of children who are exposed to violence each year, including 3 million children, see their mothers abused. That's mind-boggling to me. There's been an overall increase in untreated psychiatric and substance issues, violence, as well as media exposure. We have the cultural issues. We have poverty. Every ER visit is traumatizing for each child and all family members. Barriers are not resistance to family involvement. Again, I hate that word when people say people are uncooperative. Logistics. If you have to take 3 buses to get here and it's raining and you have small children with you and you miss your therapy appointment, that's not non-compliance on the family's part. That's poor service on the professional's part. That professional should be going into the home or providing transportation to that family. Competing demands, employment, personal problems, other responsibilities, siblings. There's so much. And then again, that psychological barrier, stigma, self-blame, their own mental health issues or addictions, etc., or their own family history of abuse. So when we're looking at the changes, we have to look at systematic changes within our own program, structural changes. So focus on the vision always, and then look at what's working in your program already and build on those existing strengths. You're going to have to make clinical adaptations, and they're going to have to continue to make them and continue to make them, because you're going to continue to build. Logistical, you may need to change staffing schedules. For an example, to make it work so our staff can go into the homes on the weekend, and we have the same budget as all the other units in our building that don't do the in-home work. We cannot have overtime, so I have some staff who work 12 hours on one day, or 10 hours on one day, and 6 hours on another day. As long as it's 40 hours in a week, we're not going into overtime. So that's just one example of just being creative. Administrators, such as myself, I'm never in the building early in the morning, because I know I need the support in the afternoon, so I generally come in 10 or 11, and I'm here till the kids are going to sleep. Or I might take off a day during the week if I need to work on the weekend to give support into the homes. So again, just looking at doing things differently, that's the logistical piece. Leadership must stay actively involved and focus on the change. You know, you can't just give a training and then expect everybody else to do the work. We all have to do the work continually. Because we are the change agents. To be effective, we need to continue to change to meet the demands of the society. So again, over time, over the next couple of days, or maybe during the question and answers, we'll just really think about what's working and not working. I like to think this is kind of like playing jazz music. We practice and we practice, and we get the notes down so we kind of know what we're doing, and then you improvise the heck out of everything, and that's when the love really shines and the good work really happens. You can really just, do that. So we focus on teamwork, and then teamwork. We have to have clinical training for all levels of staff. Supervision must be weekly, individual as well as weekly, peer group supervision. You need to be able to process what's happening. That's how staff learn. That's how we get rid of stigmas, and that's how we go deeper to the underlying issues. And it has to happen not just with the therapist, but all staff need to have this clinical level of supervision. Because if you notice, there's a parallel process going on with building the professional team relationships as well as with the families. People need immediate support and feedback. Team building is ongoing. And you really need stress management for the team members, because you're asking them to work differently, even if it's not necessarily harder. Whenever we're doing something that's changing, that adds some stress. Working in the homes is such an important piece of building a therapeutic relationship, increasing that family engagement. You have to have lots of training, and I can give handouts on that another time. We could go on forever. Focusing on safety. Relationships building there may be sometimes more informal. Again, such assessment opportunity. Going from the family picture to seeing as to how neat and tidy. Is it this? Is it that? How many people are living there really? Etc. Is there a playground nearby? Even though it's not a great neighborhood, there's a playground right there. What are the strengths and weaknesses of the home, the neighborhood, etc. You have to have protocols put into place for safety particularly. And again, we can always talk about that at a later time, because that's the whole webinar in itself, just how to do the safety in the homes. And of course, cultural sensitivity, always. A big focus, and I know that Joanne is probably going to talk more about parent support groups, but for me, they've been the pivotal part of our program, talking about, run and shoot, or practice and improvise. When we closed one unit 7.5 years ago, and then we opened into this home-based RTC, and I realized in our first week we had 5 families, because we admitted 5 kids, and the next week we were going to admit 5 more. I'm thinking all these families are telling me the same thing in admission, that they feel isolated, that nobody understands what they're going through. Why don't we get them all together? And why don't we, have dinner together? And so that was the beginning of what we call it, after 7 years, family night. Every Tuesday night, all our families, siblings, etc., come. We provide transportation as needed. They come from 5 to 6, where we have dinner and we just play games together, families and kids and staff all sitting together. And then from 6 to 7, the siblings and the therapists go off and have a sibling group, because the siblings are often the forgotten generation. And the kids do a team building activity, and the parents and the aftercare work coordinator and myself, we have our support group. And the parents who've been in the program for a while, they end up, informally leading the group, which is wonderful. We all learn from each other. It really enhances natural family supports during the treatment and post-discharge. It's supportive, it's educational, but most of all, it's just really a lot of fun. It's like organized chaos every Tuesday night. I listed a couple of, people have always asked me, well, what are topics that you talk about? People really, I ask people what they want to hear about. As your census changes, your population changes, what do you need to hear? These are some of our more popular topics. We try to rotate topics through so that every 3 or 4 months we have a new rotation going. This really focusing on positive nurturing parenting techniques, communication, nonviolent communication, structure and consistency, the biological etiology of behaviors and medication management. It's nobody's fault sometimes. This is just genetic. We do a segment on therapeutic crisis intervention for families. We talk a lot about triggers and coping skills, not just for children, but for the parents. We do stress management and anger management techniques. We talk about trauma-informed care and the power of relationships and healing, discharge planning and aftercare, and all of the above. Moving forward. So we've covered a lot of topics, and Joanne's going to talk in a moment more about the parent perspective, because it's paramount. But moving forward, take with you today and think about it, your agency's vision. Get together with your team and define, if you haven't already, what is your agency vision, and building on your existing strengths. And create a plan for change and adaptation. You have to do this. You can't just say, oh, I want to be family engaged. You have to figure out how your agency is going to do it today. And it may be different next year. How will your agency staff work together to develop and implement a plan for just really, truly increasing their family engagement? And involve family partners in the development as well as ongoing program maintenance. That's important. And then keep it moving. And so thank you for your time and attention. And I know you're really going to enjoy listening to Joanne, who has years and years of experience not only as a parent, but also as an administrator and consultant in this never-ending field of mental health. Thank you.
Hi, everyone. It's Joanne Hust. I'm a parent, and my daughter was in residential for probably a little bit too longer than we had expected. I'm going to talk to you today about what that experience was like for us as a family, as well as other parents' experience. I'm so glad that everyone's joined us today, and it's good stuff. Don't you just love what Patrice and Sherri have been saying? It just gets me excited. It's just, for me as a parent, I love the change, and let's keep it moving forward. Get ready to roll up your sleeves, everybody, because if you're a part of BBI, we're going to get you moving. I was offered a position as a parent partner in a wraparound after my daughter, during the time my daughter was in residential. And I worked in wraparound. All the values you've seen today were the values of wraparound, and yet I had a child in residential. And there was this dichotomy between the two that just wasn't jiving. And I realized that a lot of the things that I was being told and that we were learning in wraparound, the high levels of family involvement and getting families involved and, helping families build skills that transferred from home to school and community so that there was one plan, and follow along care after placement or aftercare and shorter lengths of stay were all things that led to good outcomes. But what I saw as a parent personally, and a lot of the parents that I talked to, was that my family contact with my child was limited. There was only a certain time that I could visit with her. There was only a certain time that we could talk on the phone. when we would go in to have our family sessions, there was such a focus on the milieu appropriate behavior, on, you know, what girl had said what to whoever and who was doing what. And I was just looking for skills that really we could take home and that would help us when she was in school and out in the community. When she was discharged later, it was like we fell off the face of the map. There was not a follow-up for aftercare. She kind of just, you know, fell off the system. And luckily, we, you know, being the parent partner at the time, I was able to, you know, work on that piece. But the follow-along care for aftercare, just, you know, it's more of a handoff to the referral to a community-based provider. And as families, we need that to be consistent. We don't need to keep having to tell our story over and over and over again. And then shorter lengths of stays that I heard that were leading to better outcomes for us was absolutely the opposite. Is, you know, I was told that maybe it would be best if we let her stay there until she was 18. And thank heavens for wraparound. So you'll hear me talk a lot about those values today as we go through this. Because of my experience personally and working as a family partner, parent partner, family advocate, whatever you want to call it, in a large children's mental health agency in California, Los Angeles, I ended up going to a BBI summit in 2005, and the rest is kind of history. Got involved with the family advisory group. And what I'm going to be talking to you a lot about today is what took place based on the feedback from families that we were working with. A few years back, as part of BBI, Family Advisory, we proposed an idea to the powers that be at BBI about a paper that was a paper or a document written by parents to residential providers to let them know what we as parents really needed to engage us, what would be helpful for us as family members. And so as time went on, the idea hatched. I ended up being the lead writer on that. And we gathered several groups of families together, and we got feedback. And we asked parents, what did you need? What was it like for you? You know, as parents who've experienced residential with their kids, we've all entered residential in a different way. Some of us through child welfare or juvenile justice mandated, and others of us, like myself, through mental health. But even though our experiences are different, the thing that we all had in common was that we all wanted a better future for our child across the board. So some of the themes that came out in these meetings with families and parents like myself, that they, across the board, were really about services in general. Parents kept asking that the kinds of services that will avoid out-of-home placement were available. Community-based programs, sometimes in some areas, are few and far between. Being in Los Angeles at the time, it was still slower than, you know, I'm seeing now. Thank heavens for change. Families asked for short-term options that were close to home. If they had to place their child out of home, how about some short-term options? And how about that we don't have to send our kids all the way out of state? How about if we keep them close enough that we can hop in the car and drive as often as we need to? When placement is unavoidable, families ask that they be acknowledged that the loss for them is real, and do everything you can as providers to preserve the normalcy. Involve us day to day, not just as visitors or, you know, the parents that come on a certain day. Involve us so that we can walk on campus at any time. And I know that probably is a scary thought to a lot of you, but Those are the kinds of things that parents ask for. Assure that there's two-way communication, not just with the child, but also with therapists, milieu staff, whoever has anything to do or involvement with the child. We want to hear what you have to say. Invest in highly skilled staff who use best practices and share the goal of helping our child return home. And then provide access to peer support, parent partners. Number one, that across the board, for all of us, you meet another parent that's been through what you've been through, and you think you're the only one, that no one else in your city has ever had anything like this happen to them, and you meet someone else that has walked in your shoes, the connection and the bond and the amount of empathy and understanding is amazing. And so all of the parents ask for peer support and foster hope and resilience. Don't be a downer. I know for us, it's easy enough to be down about what's happening. We're grieving. This is a difficult time for us, but we need hope. And sometimes it needs to come in little doses, a pat on the back, a phone call, but we need hope and provide that hope. More specific to residential, families ask that you ask us for our opinion. Don't just ask us at intake, tell us your story, and we've told it a million times. Ask us what we think. Learn what our goals are for our child. They may be, and often are, the same as yours, but ask us what we think as well. Also, what's been tried? Let's not repeat something that we've tried before that really didn't work. What worked? Ask us what worked, because that's what we really need to focus on. Keep us informed and involved on a day-to-day basis. I often felt like on Monday mornings I'd be calling about something that had gone on over the weekend, and they were dreading hearing from me. You be the one that makes the call. Don't have the parent always the one that is trying to keep up with the day-to-day happenings. Be honest again, but hopeful. Treat us with dignity and respect, and create a program. This was a big one. All of the parents said, would they put their child in this program? And so create a program that you would choose if you needed the help for your son or daughter. Really gives you a lot to think about there. A lot of this information ended up going into the guide that's on the Building Bridges website at Building Bridges for Youth, numerical number 4, for youth.org. And it's called Engage Us. And if you haven't read it, please do. It's a great resource for providers to hear kind of the other side of the coin from families. And there's also a great section there on family finding. Patrice talked a lot about, the child needs to live in a family. And so we actually put in a whole section on family finding. Perceived resistance. I often laugh when I go out and present as a parent because people will tell me, well, but you're not, you don't understand. We have parents that just are very resistant. And I laugh because I say, well, maybe I'd clean up well. But we've all been that parent. We're not just the parent of the child that's in placement. We may come across, we have other things going on in our life. We may come across as being difficult or angry or a lot of mama bear energy going on, or reluctant, like, this probably won't work either, because we're at the end of our rope. This is usually not the first thing that's been tried for our child. Maybe we're not able to remain sober, or we dismiss that it's not mental illness, it's just willful behavior. Or maybe we're no-show. There's a lot more going on there. Patrice talked a lot about this too. We're fatigued. We often have other children. Sometimes there's health issues at home, either for us, for family with other children. Maybe this isn't the only child that's receiving services. There's possible trauma in the family, mental health or substance abuse, and we're just trying to keep a roof over our head and food on the table. So when we get our children to residential, often it's a time when maybe parents might step back and think, okay, well, this is my chance to take a breather and catch up. That's the time you need to be relentless, and you need to be supportive, and you need to really be creative to get that parent connected. Don't give up. Keep trying. If what you're trying to do to get them involved doesn't work, give it time, try something else. Sometimes and often, and I know all of you probably know this, is that there just is maybe a need for relief, stabilization, and support. If they don't have food on the table, if they don't have the money to buy diapers, if there's domestic violence going on in the house, if there's substance abuse going on, it's pretty hard to focus on this. And eventually, with support and stabilization, parents can get to a place where we can be involved. Don't give up on those resistant parents. Oftentimes it's just perceived. Don't give up, don't judge them, and don't, by any means, please, don't label them. Working with siblings. This was a big topic that came across in talking to families. It was crucial because so many of us talked about, our other children, that there were almost a price that you pay for having your child in residential with the rest of your family. You're so focused on helping that child in residential get better that oftentimes things within the family go unnoticed. Parents ask that residential providers focus on the entire family. The entire family's hurting, and the siblings suffer. Working in wraparound for myself, the paradigm shift from focusing on just the child in treatment or the child with the challenges to focusing on the entire family and supporting the entire family is the base of what we were doing. But we really need to do that with all work that's involved in helping families, because children don't live in isolation. They don't live in a community or a school. They live with a family. And so we need to make sure that when that child returns home, hopefully sooner rather than later, that the entire family are doing well and can work together. Families ask that providers develop expertise working with siblings and supporting siblings, and especially thinking that the child in care behavior impacts the entire family, and especially siblings. Parents often talked about, hearing from the siblings that, that they were worried that the parents were going to place them in out-of-home placement or not keep them at home because of what had happened to their brother or sister. And there's a degree of sadness that goes along with that. I mean, it's almost as if while the child's in treatment, that the rest of the family can't be happy or can't be normal because they're grieving and they're waiting for that child to come home. So think about how that impacts the work that you're doing. And make sure that you create opportunities to maintain and repair those sibling bonds. Group activities for siblings is great, but one of the things that as parents we know has really worked well was the ability to focus on the relationship between the child in care and that sibling, and just the normalcy of them being able to do something that doesn't focus solely on the behaviors of the child with challenges. And benefits of working with parent partners. And I know a lot about this because of the work I did working in wraparound. I was lucky enough to get hired as their first parent partner, and it put me in a place where I was able to attend a lot of meetings and learn a lot of stuff and go through a whole culture change within the agency. I will tell you that the presence of parents within a large or even a small provider agency changes the culture. I was lucky enough to actually work for the provider. I didn't work at a family organization until much, much later. And working within the agency, you know, it was hard for folks to talk about us when we were sitting right next to you at a desk. We made sure that we integrated our parent partners as we hired more into the program, and that we weren't off in a room for just parent partners, that we were integrated into the rest of the work that we were doing. It creates this conduit between treatment and the family setting. So there's, you know, while Patrice talked a little bit about the professional boundaries that you have to keep as therapists or childcare workers, with parent partners, we're hired to tell our story. And so it is crucial that that we talk about those types of things. Parent partners provide peer support. We can act as co-trainers in staff orientation, part of HR groups, evaluation teams. If you read any of the BBI stuff, you'll see all of this information readily available for you. And really, I can't emphasize this piece enough. Recruit parent partners, develop clear role description, offer them compensation equal to others, convert their lived experience and education requirements into dollars, and provide flexibility, a big piece. At the end, I'd like to leave you with this quote or saying from Barbara Burns, written more than 19 years ago, but it really wraps up what we're saying today. We hope you enjoyed our webinar. My contact information, if you need to send questions, and I'm going to pass it back to Sherri for questions and answers.
Thank you so much, Joanne. And Patrice, what great information the both of you provided. At this time, I'd like to go ahead and open up our session for question and answers. While we're waiting on questions, I just want to highlight a few things and also let you know that Joanne is no stranger to the folks in Texas. She was very helpful in helping get us started on the Texas Family Voice Network and that group, that statewide network going with the system of care work. So some of the highlights that I mentioned is that there's 3 things that you can do to really encourage your partnership with families. Is first, ensure that permanency is a priority, and secondly, that you're hiring family advocates or family peer partners, you know, whatever a respectful term is, and then third, that you're strategically planning with an eye for family engagement and family partnerships. So you're purposefully, and that brings in the leadership and helping guide that process. And then Patrice had a whole bunch of good advice as far as ensuring along those lines with strategic planning, assuring that the mission and vision is synced up, that there is a focus for inclusion of the entire family system and how to be more inclusive. She gave us ideas for that with the composition of the team and really looking at family strengths, face-to-face meetings in the home, you know, addressing culture and trauma. And then Joanne followed up with really the need for communication between the youth that you're serving and families, and the need for aftercare. And she laid out a great piece on the work of family peer partners and how they can be utilized with peer-to-peer networking and training and evaluation, and overall just the need to communicate that hopefulness in the work that you're doing. So with those little tidbits of highlights of the different areas, I'll open it again to any questions or comments.
Sherri, this is Joanne. I have a question. have we, I'm imagining that there are probably maybe some residential providers on the line, and I'm wondering if currently family partners are being hired to work in residential in Texas.
You were reading my mind, Joanne. I couldn't, I was on mute. But what stuck in my mind when I listened to your talk again today was that that's one of the most important things I think we did here at Catholic Charities. Was years ago we hired one family liaison advocate, and now we have a team of people. And they actually sit in on all of our treatment teams as well as run parent support groups, and they're beyond amazing, and they really help us keep it real here and down to earth and making sure that we're meeting the needs of the whole family. So that is such an important piece of information.
Yeah.
That's a good question, so we'll open that up. I know from on the community side, for the community mental health centers and all that, family partners and have been hired, especially with work with wraparound teams and all. So we'll just open it up to respond and see if there's residential programs that have hired family partners.
We're looking into it. Are we looking into it? Doesn't the region have somebody?
Sherri, this is Jenny Henson.
Hey, Jenny.
How are you?
I'm doing well.
So I'll take a stab at answering this question. So I'm not aware of any residential treatment centers that have hired parent partners. However, after the meeting that we had in Houston, where we really re-engaged the community and started identifying strategies to implement the BBI framework, several have indicated that they're looking into that and are, determining whether or not they are able to bring that position on. I think they have to look at, just where they are operationally and funding-wise. One of the things that we did at the meeting, though, discuss is, so we have a parent liaison that works for CPS. She is a parent that was involved in our system years ago. And we have what's known as a parent collaboration group, which is a statewide group consisting of parents who provide input and onto policy and practice and provide support to our regions. We're broken up into 13 regions, and those regions have parent support groups. And those parents help other parents who are in the system, or whose children are in the system, rather. And so what we have tried to do, and we're in our infancy, is our parent partner here at state office, our parent liaison, is a part of the BBI work group. And at the meeting, we really tried to create some visibility around the parent partners that we have in our existing system, and to create opportunities where residential treatment programs who are looking to implement these practices could work with local parents in order to, help them advance that, et cetera, et cetera. And so we're very early on in it, but I definitely heard a lot of excitement and interest in moving in that direction.
Thank you for that background and response, Jenny. That's helpful.
Jenny, this is...
Go ahead, Joanne.
Well, I was just going to say, Jenny, I'm so glad to hear that you are providing families to give input and to support of their parents. One of the things that I think that, at least in my experience, that we forgot about in LA was that that parents, while they were parent partners or family members that were great at supporting other families, but the thing that came as such a surprise was just the presence of hiring parents or having presence within a provider agency or, involved in a provider agency changed the culture of the agency, because, I can remember, working in a mental health agency and people coming up to me and saying, hey, Joanne, I think there's some parent partners kind of wandering around here. You better go round them up because, they're not supposed to be here. And we laughed because we had hired them. And, they'll oftentimes, as parents, we're not always great with the way we say things, but we would challenge kind of, assumptions by our professional partners on some of their thoughts about how they might engage a family. And that, for us, was such a huge piece of the culture change that actually took place, was that just having family members around working directly with, and by shoulder to shoulder with the providers really created a huge impact. Just wanted to throw that out there as a thought.
So thank you, Joanne, and I don't think anybody could have said it better. Anytime we bring in, parent and youth voice, it really makes folks kind of take an opportunity to perhaps reconsider language or reconsider practices. And so we'd love to see our facilities here in Texas move in that direction. We definitely have let them know that there's no barrier to doing that, and we'll just continue to encourage them to do it.
That's great.
Okay, good deal. Any additional questions? I think that's good conversation, and it would be interesting even, to hear on the places, in Texas that they've moved to that next level of hiring family partners, how that has benefited. But I think it sounds like everyone's in agreement on that. It's just finding the ways and means to prioritize that, with budget and all. Additional questions about engaging families within residential interventions and partnering with families. Got a few more minutes here.
This is another topic near and dear to my heart. How many of you actually have therapists or staff working in the homes with your families, those of you from residential treatment centers? We have found here that actually working in the home in addition to the treatment center just has really enhanced their level of family engagement, 1,000-fold. So I was just wondering, and I know lots of people in the country are doing that, but some are not. So I was just curious what's happening in Texas.
So this is Jenny again. I'm not sure if do we have providers on the line?
It looks like there's some in the participant, but remember, if you've muted yourself, to unmute yourself if you would like to speak. But Jenny, you can speak on behalf of Texas again if you'd like.
To my knowledge right now, we have not implemented that practice here in Texas. We are steadily moving in that direction of really doing more cooperative and collaborative service planning and parental inclusion in treatment for children that are in foster care, including children that are in residential treatment. I always want to say this to folks. It takes a little bit of time to get things fully integrated here in Texas. We have 254 counties. We have 30,000 kids in foster care and over 300 providers, about 70 of which are RTCs. And so we have been laying the foundation so that we can remove any licensing barriers, contract barriers that would prohibit, parents from being able to go to programs. And I do know that several of the programs are looking at the aftercare requirements and providing some in-home counseling. And so that's happening really concurrently with the work that we're doing with BBI, as well as folks looking ahead to Family First So we hope to get there, and I can tell you that the folks that I've talked to, some of them are very interested in what you guys talked about on the webinar today, the whole, concept of kids going home and having case managers and others support children in the homes that they're going to return to. And I would imagine that you might get some questions after this.
Thank you,
Great.
Jenny.
Thank you.
And thanks, Patrice. I know in days ago, and that's why I'm so glad and excited that there's good leadership and awareness from our child welfare agency in Texas, because I know the RTC project had removed the joint project between DSHS and DFPS was really looking at, making sure that there's some fluidity with the continuum between residential and working within the home with residential intervention and working, with families in the home. So hopefully that's carrying forward. So like you said, we're a big state, but I think looking at some of those demonstration efforts helps inform wider spread implementation. So we'll open it up. I know we're at 11:30. So if there's a last question or comment from anyone, we'll get now.
Now it's meeting?
Okay, hearing none, I'll turn it back to Glenn to close up with any additional guidance.
All right, thank you everybody for coming. We'll get this posted online as soon as we can.
Thank you, Glenn.
Thank you all.
Thank you.
Thank you.